to call additional help if I need it. Consider stabilization of C-spine. I'm going to verbalize my general impression of the patient. Patient is unconscious. He's lying down. He looks like he is sick. I need to attend to him right away. I'm going to determine responsiveness using AVPU, alert, verbal, to pain, or unresponsive. So I could use a trapezius pinch to try to see if he's alert to pain, if he's not responding on his own, which would be alert, or to my voice, which would be verbal. And then I'm going to determine the chief complaint and any apparent life threats. We were called out for chest pain for this guy, so I'm going to assess the airway. I'm going to open it, look, listen, and feel for breathing. I'm going to initiate oxygen therapy if the patient needs it, assure adequate ventilation by looking at the chest rise. I'm going to assess the patient's circulation, control any major bleeding. If I see it, I'm going to check a carotid pulse, and I'm going to check the patient's skin signs, color, temperature, condition, which is moisture, and capillary refill. Then I'm going to identify if this is a priority patient, make a transport decision. Do we need to load and go, or can we stay and play? And then I'm going to do my sample history. I'm going to find out signs and symptoms of this patient. If he's alert, I'll get it from a family member or bystander. Signs would be objective things that I can see with or gain with my senses. Symptoms would be something described by the patient. Under signs and symptoms, I would find out for cardiac OPQRST, which is onset, provoking factor, quality, radiation recurrence, severity, and time, and interventions. If this, for instance, was a cardiac patient, let's say he took his own nitro or used oxygen at home, I would try to find out when interventions were already done. I would get allergies, medications, find his past pertinent history, what his last oral intake was, and events leading to present illness. And then I would do my focused physical exam. Because it's a cardiac patient, I'm going to focus on the chest area. So first I'm going to inspect. I'll see if there's any scars, see if he has a implanted defibrillator pacer, a nitro patch. Maybe he has a medical alert tag. Maybe I see JVD. That would show me that the heart is backflow. Then I'm going to auscultate. I'm just going to listen to lung sounds. And I'm going to listen to the apex of the heart, make sure I get a good feel for what the heartbeat is. And then I'm going to palpate, just see if I can reproduce this chest pain that the patient is telling me about, because if I can, then it's probably not cardiac pain, it's probably musculoskeletal. Then I'm going to get a baseline set of vital signs. I'm going to do any interventions. Let's say over the radio they told me I could give some oxygen, assist the patient with their nitro, maybe give an aspirin. I would do all those things. I'm going to transport the patient. I'm going to consider a detailed physical exam, which would be a head-to-toe assessment based on the patient's complaint of chest pain. And I'm going to do my ongoing assessment, which would include repeating my initial assessment, repeating my vital signs, and repeating my ongoing assessment.
Okay. I got that.